Right, thank you very much for the introduction. So for those of you who have just joined, if you wouldn't mind scanning the QR code on the left-hand side, and if you want to join in the in the questions that I'm going to show. So it's all anonymous, so we won't know who answered what. So, and it's just for a bit of a fun, and hopefully makes learning a bit more interactive. I'm just going to give everybody about 30 seconds to sign into the Mentimeter QR code. Right. Okay. So the topic that I was initially given was palpitation, and which is quite broad. And I thought that maybe we'll include in some management of acute arrhythmia in a DGH setting. So that it's more interesting, because palpitation is a symptom, and it can be associated with many other things other than cardiac, and and this session is obviously focusing on a cardiac session. So let me move forward. Right. Okay. I'm not, for whatever reason, I can't move forward. Oh, there we go. Okay. So learning objective, we're going to talk about different type of tachyarrhythmia in children, how we're going to manage it in an acute setting, and when to refer to the Pediatric Cardiology Center. And I'm going to use case-based as throughout this presentation, because I think we all learn better with cases. Okay, so some introduction. Arrhythmia in children. Approximately 2% of school-age children will experience some sort of arrhythmia in their life. And thankfully, true emergency due to unstable arrhythmia in children are pretty rare. So the commonest tachycardia in children, or when they complain that they have palpitation, is actually sinus tachycardia. But the commonest tachyarrhythmia in children is supraventricular tachycardia, or more well known as SVT. So I'll explain slightly more about the term we use as SVT in the world of pediatric cardiology later. Okay, so in this diagram, this is how the way I look at, categorizing tachyarrhythmia in a child. So first of all, you break it down into, is it narrow complex, is it wide complex, and then after that then you look at the regularity of the rhythm. Is it regular? Is it irregular? So if we look at the narrow complex tachycardia, if it is regular, so then you need to think about the mechanism of the tachycardia, because this will influence how you're going to manage the child, and you can actually predict how the child is going to respond to the treatment that you're going to give. So when we are talking about SVT, we are actually talking about reentrant mechanism. So the AVRT, which is an accessory pathway mediated tachycardia, and the AV nodal reentry tachycardia. So for the rest of the abnormal tachyarrhythmia rhythm, we try not to say that SVT for atrial-ectopic tachy, junctional tachy, so on and so forth. So just to make clear that when we are talking about SVT, we are talking about AVRT, which is a pathway mediated, or AVNRT, which is a where there is a reentrant circuit in or around the node itself. So I'm not going to go through all of these. You can have these slides if you want, and then you can study it after. But essentially, when you're seeing a patient, break it down into, is it narrow or wide complex, and then look at the rhythm. Is it regular or irregular? Okay, so in terms of mode of presentation of arrhythmia, so it depends on the age of the patient and how long the patient has been in the having the tachycardia, and also the type of tachycardia. If it is a child, they will be able to tell you that they have palpitation and other symptoms like shortness of breath, dizziness, chest pain, or they can't really do much when they're having this tachycardia, and sometimes they can present with heart failure as well. With the neonates, obviously, it's more difficult because you don't know when the child or the baby goes into tachycardia. So they often present much more poorly, with sometimes mimicking a septic like picture due to heart failure. Otherwise, it will be like poor feeding, lethargy, not really themselves, um, and increased rate of breathing or tachypnea. Okay, so with regards to presentation, depending on the type of tachyarrhythmia, so with the SVT or the reentrant tachycardia, the child usually will present with palpitation. They'll complain of palpitation. They'll say that their heart is beating fast or funny, chest pain or dizziness. These are the arrhythmia which, like atrial tachycardia, persistent junctional reciprocating tachycardia, jet or junctional ectopic tachycardia, frequent premature ventricular complexes, because these type of tachycardia are more incessant. They can come on multiple times a day, lasting for, couple of hours to 6 or 7 hours a day, and because of that, the child actually get used to to the heart rhythm, so they don't often complain of palpitation. So by the time they present, usually incidentally, for some other various reason, you do an X-ray and you notice cardiomegaly on the chest X-ray. So they usually present with heart failure. And with regards to syncope and sudden death, obviously this will be more malignant type of arrhythmia, like polymorphic VT, whether it's due to channelopathy, whether it's due to scarring due to cardiomyopathy, uh, and VF, obviously, the patient will be in cardiac arrest. And then pre-excited AF, which is important to be aware of, because patient with accessory pathway, all patients with accessory pathway, in fact, are at risk of pre-excited atrial fibrillation. And I think it's really important to recognize this, because there are certain drugs that you would want to avoid, so that to make sure that you're actually treating the patient appropriately. Okay, so how do we approach a patient with tachycardia or palpitation, present to you complaining of palpitation? So always take a good history, take a comprehensive history and do an ECG. If you need to deliver treatment to the patient, then make sure that you do the ECG before giving antiarrhythmic if you have time. And there is always time, because um, by the time you ask the nurses to draw the medication up and things like that, you have those time to put an ECG on, and it's not going to take very much time to get an ECG before giving the antiarrhythmic of your choice. And it's also important to document the ECG during during administration of the treatment. Main reason is because it actually sometimes it can actually help us in a tertiary center to figure out what type of tachyarrhythmia that we are dealing with. And also useful to do it after treatment, because if you see a clear termination, how the tachy terminates is also important. And I mean, it helps us to, gives us an idea. Can't 100% be diagnostic most of the time, but sometimes it gives us an idea. Does the arrhythmia terminates with the medication, whether there's any response, and what type of response, if there is. So it all depends on how the patient is when the patient present. If the patient is hemodynamically stable, then you can try adenosine. Bigger children, you can even try oral beta blocker, to be honest. And other medication include flecainide and amiodarone. If the patient is unstable, obviously, then you have to move on a bit more swiftly. Think about DC cardioversion. Think about stabilizing the patient, intubating and sedating before you actually deliver the shock, because it's very painful to shock and awake child or baby. And it's putting a patient with uncontrolled arrhythmia onto ECMO is rare, but it does happen. Right. So I've got 6 cases. So let's see how we go. How we go with time. Hopefully, I can present all of them because they are all very different and they are all based on real life cases. So we've got a 2-week-old baby. Coryzo for about a week, poor feeding, lethargy for about 48 hours, and found to be tachycardic. So came to your A&E and with coryzo symptoms. And when the nurse put the do the observation, the baby has tachycardia. You examine the patient. The baby looks slightly pale, fractious but consolable. The blood pressure is normal. So this is the ECG. For timing's sake, I'm going to describe the ECG for all of you, and then I think I have question coming up after this. So it's a regular tachycardia, and at the rate of 250, 270 beat per minute, and so narrow complex regular tachycardia at the rate of 250 to 70 beat per minute. A little bit of ST depression in ST in the chest lead. Otherwise, it's just narrow complex. Right. So you gave the child 150 microgram per kilo of adenosine, but you only have transient termination of the tachycardia. What would you like to do next? If you can start voting. I'll give people maybe 30 seconds to vote. Great. Okay, I'm going to move on to the next question. So you've tried 200 microgram per kilo and still only transient effect. What are you going to do next? The child is still the same. So still hemodynamically stable. Right, okay. And then, so you've tried 300 this time and you get a slightly longer termination, but then the tachy restarted again. The baby is still hemodynamically stable. And what do you want to do now? Okay. Right. I like the selection of the answer. Okay. So we all know that we have all faced this type of patient where you give adenosine and it terminates for a few seconds and then the tachy restarted again. You keep going up on the dose and then the tachy just keep coming back. This is actually not uncommon. In a paper which was written by Crosson in 1994, they look at the adenosine administration in children who presented with SVT, and they found that 28% of the children who have had effective adenosine administration do not have sustained termination. And the reason is because this is, sometime when the child has been in the arrhythmia for a certain period of time, they have this adrenergic surge in their body, which promotes the continuation of the tachy. So the half-life of adenosine is very short. So the moment the adenosine wears off, you've got the adrenaline in the body that then promote the tachy again. So that was the reason. And what we should be doing is that if you've given 150, it doesn't work, then you should go up on a higher dose, because sometimes you might just need that higher dose to terminate it if you're very lucky. And if it still doesn't work, you've gone up to the maximum dose, like in a 2 weeks old. So anybody less than a month old, the maximum dose will be 300 microgram per kilo per dose. So not the total total dose that you've cumulative dose, but actually the individual dose. And then trying the patient on, if the patient is still hemodynamically stable, then you can give them a dose of oral beta blocker. Obviously, if it's, the child is a bit more compromised and you want something a bit stronger, then you can give IV amiodarone, and then try giving and then see whether it stops the tachycardia. Because this medication, amio beta blocker, they have, they are not a fast-acting medication, so it takes a while of time for it to work. If it still doesn't work after, let's say, 30 minutes to an hour, the child is still stable, then you can try giving IV adenosine. And most of the time, after giving a longer acting antiarrhythmic and repeating an adenosine, you can actually terminate the tachycardia. So it's an option for patients who are not very hemodynamically compromised. Okay, so case 2, you have a 2-day-old term baby presented to the hospital with jaundice. So midwife referred this baby to you with jaundice, and on examination, the baby is slightly tachypnic, but otherwise well. All the hemodynamic status is stable. And this is your ECG. I'll let you have a moment looking at this ECG. So what I'm going to say is that I'll give everybody 30 seconds to have a look at this ECG. Slightly fast. 2 days old. Well, I wouldn't really say fast. I mean, it's about 150 beat per minute. Okay, ready for the question. What do you think the ECG shows? Just put something, even if you don't know, just put something. Don't worry. Your name is not going to show up here. Okay, great. Let's move on. So based on your answer, what's your next step of action?
No, no continue like
Oh, we've got a lot of people answering this. That's good. Great. Oh, oh, sorry. I think some of you are still answering, but really sorry. Okay, so you gave adenosine, didn't really work. It still looked, so there's an arrow showing where the adenosine was given. Seems like it's still going on. Right, okay. Let me see if I have, no, okay, right. Oh, okay. So this ECG actually shows atrial tachy. Sorry, not atrial tachy, I mean atrial flutter. It is very difficult to see it sometimes, and you can easily mistaken it for sinus tachycardia if you're not very careful. So if you look at the limb lead, I think lead 3, 2, 3 are actually pretty good. So those are your sawtooth wave. So you can see that, you know, this P wave looks exactly identical to the next one here. And you can actually march them along. So if you look at the long rhythm strip in lead 2, you can march them along. So these are flutter wave. And so this is 2-to-1 flutter, atrial flutter with 2-to-1 conduction. We don't say as, you know, block, because there's nothing, you know, the AV node is not blocked. It's just that the atrial rate is going at 300 beat per minute, and not every single P wave are able to get down to the ventricle, which is a good thing. So this is atrial flutter with 2-to-1 AV conduction. In baby, it's, you know, it's always a bit more difficult to see the flutter wave compared to older children, where you can really see the flutter wave more obvious. And right, so I think some of you, I can't remember what was the answer now. Some people say that you can try adenosine or beta blocker and stuff like that. To be honest, adenosine often doesn't work in atrial flutter, atrial tachy type of things, because these arrhythmia are triggered by automaticity, or in atrial flutter is due to a bigger macro reentrant circuit. So very often adenosine doesn't work. And the way that adenosine work is it's basically it binds to the A1 cardiac receptor, and it um, inhibit the calcium channel, and also enhance potassium conduction. So it alters the SA and the AV node action potential, and so make it a bit more refractory. And this is why this is how it terminates tachycardia in a reentrant circuit. So any circuit that's involved AV node, then it's going to terminate. It is going to be more effective. So a bit more about adenosine. It's rapid onset of action, but has a very short half-life, less than 10 seconds. The moment it has contact with any red blood cell, it's going to start starts to metabolize. So you need to give it through a large bore cannula, free of blood. So the cannula has to be free of blood, and insert it into a large vein as close to the heart as possible. So ideally, the cannula should be placed in in an antecubital fossa, and then give it as a fast bolus followed by a large saline flush. It's ineffective via intraosseous route. So just bear that in mind, because when you have a child with a baby presented with peripheral shutdown, and you can't get a cannula in, then just bear in mind that you can try intraosseous adenosine, but most often it's not you're not really going to do anything. Okay, and so adenosine. So once you've given the adenosine, you will observe one of the three effects. So number one, the tachy terminates, and you get your sometimes you get your diagnosis. For example, in here, there's a tachycardia going on, narrow complex tachycardia going on, and then it terminates, and then you've got pre-excitation. So you know that this is SVT due to a reentrant circuit, which is AVR, which is this particular SVT is called AVRT. Okay, and it can be diagnostic if it's as well. So if you have tachycardia going on, you give the adenosine, then you start seeing a flutter wave coming in. So you know that you're dealing with atrial flutter, and giving more adenosine is not going to work. So we'll have to try something else. And sometimes you give adenosine and nothing happened. The tachycardia just continue to go on. So this could be due to failure of administration, such as the cannula is being placed too distally, such as the foot. You've given inadequate dose, or you've given it too slow, or it's a adenosine-resistant tachycardia, such as atrial tachy, atrial fibrillation, atrial flutter, or VT. So I think I've already explained about reentrant tachy, so I'll just go through it very briefly. And so as I said, reentrant tachy, there's a circuit that is being involved. So you always involve the AV node. And then, for example, in this diagram here, I don't know if you can see my cursor, maybe not. On the diagram on the left-hand side shows that this is a accessory pathway mediated SVT. You've got often started by some sort of atrial ectopic, and just so happened that the accessory pathway is not refractory. So you've got atrial ectopic goes down the AV node, and then the accessory pathway happens to be awake and not refractory. Then it goes up through the accessory pathway to the atrium again and start off a reentrant tachycardia. Similarly, in atrioventricular nodal reentrant tachycardia, your short circuit is close to the AV node and involve the AV node. So you've got, again, this reentrant tachy. So adenosine are usually very effective in these type of in reentrant tachycardia, because if once you manage to block the AV node at a sufficient amount of time, it's going to break that tachycardia off. So in terms of the dosage of adenosine, you can find this in BNF, but essentially less than a month old maximum dose is 300 microgram per kilo. This is, I'm talking about single dose, not cumulative dose. So you can give, multiple 300 mic per kilo if you want, and because it's going to metabolize very quickly. And then above a month old, under 12 years old, maximum single dose will be 12 milligram or 500 microgram per kilo. And then in the teenager, you go from 3, 6, 12, 15, or sometimes you repeat the 12 for a few times. Just to be aware that heart transplant patients, they are a bit more sensitive to adenosine, so you might want to give a lower dose. Okay. So next case 3, we've got a 8-week-old baby. No antenatal concern, born without any problem, and presented with coryzal symptoms, poor feeding for the last 24 hours, and sleepy as well. So parents decided to take her to A&E. You examine the child. She's cold to touch. She's mottled. Her cap refill time is It's not CRP, CRT. Cap refill time is 3 to 4 seconds. Heart rate on the monitor is 330 beat per minute. And the nurse said that the systolic blood pressure is 117 millimeter mercury. You managed to, you didn't manage to get a cannula, so you did a heel prick, and you've got a lactate of 6.5. So and had multiple attempt in inserting an intraosseous access, but managed to eventually get one in. So this is the ECG. I'm going to give you a bit of time looking at this ECG. So it's tachycardic. Baseline is not quite regular, not like the first one, the first case that I've shown you, especially if you look at the beginning of the tachycardia, you know, the first half of the rhythm strip over here. Okay, I'm going to move on now. So how would you manage this child? You've got an option of IV, I shouldn't say IV, but adenosine via intraosseous route. You're going to electrically shock this child. You're going to sedate, intubate, get central line for IV adenosine. You're going to give IV amiodarone via intraosseous route. Right, okay. Right. Okay, I'm gonna move on. So, sorry, I can't remember what I've put in the slide. Okay, so I agree with the electrical shock and the sedation, intubation, and getting a central line for IV adenosine. When we are thinking about electrical shock, just bear in mind that you've got this child in front of you, you have no access, and ideally you want to sedate this child with ask the help from your anesthetic colleague to sedate this child or intubate this child before you actually shock the child, because don't forget that the baby is still awake, and even though it's peripheral shutdown, but she's actually still awake. So if you're giving an electrical shock to a awake child, it's actually quite painful. And as we said before, IV adenosine via the intraosseous route, they often don't work. So I think in this situation where you have a child who is peripheral shutdown, even though the nurse said that the blood pressure is high, but I'm not sure you can rely on that, because on an automated blood pressure in a shutdown child, you got to think twice. You got all other parameters to say to tell you that this child is not, that blood pressure cannot be true. So I think the right step would be to sedate, intubate, get a central line, and either go for electrical cardioversion or try the adenosine if you want. So the adenosine was given via intraosseous route, and I don't think it actually terminates. I think, if you look at the ECG strips over here, I think this is definitely not the standard SVT that we're dealing with, where you get regular narrow complex tachycardia. I think these are just variable AV conduction down the AV node from whatever the tachycardia, the origin of the tachycardia. And so let me have a quick look. Okay. Right. I have no further question here. Okay. So in this ECG, I can't even remember why I put it in now, but I, I guess it shows that it's more irregular, And if you see this ECG, you know that something is going on because the baseline, the P wave is not quite normal, it's quite peak. And you don't see P wave in front of every single QRS. So this raises your suspicion that this cannot be a standard sinus rhythm. And usually atrial tachycardia, because the atrium are firing and it doesn't really have to involve the AV node to sustain the tachy. So you often, sometimes, if you're lucky, you can get one-to-one atrial tachyconduction, but it's also not uncommon that you get more A's than more V's. So looking at the overall ECG, you're not dealing with a reentrant circuit. A reentrant circuit will always have a regular cycle length, or sorry, regular heart rate, because the tachycardia is practically going in a circle. Whereas for things like automaticity, like atrial fibrillation, atrial ectopic tachycardia, junctional ectopic tachycardia, they are not going in a cycle. The myocardium of the that is involved in the arrhythmia is practically just firing at a certain speed, regardless of whether it conducts down the AV node. Atrial tachy often do not respond to adenosine or DC shock. It is diagnostic giving the adenosine, so I'm not saying that don't give. If the child is very stable, give it, because if you manage to slow the AV node down, then you will see more ACE. And then that it is actually helpful when you want to speak to the to your cardiology center, showing them the traces, because that will help them to help you. So in atrial tachy, the priority is often given to rate control, because atrial tachy is notoriously difficult to rhythm control. You often can't get the patient straight into a sinus rhythm immediately. So what you want to do is to control the rate so that you slow down the ventricular, the conduction to the ventricle. So you can do rate control by giving IV amiodarone, digoxin, beta blocker, flecainide. You got to bear in mind that all of these antiarrhythmic, they are negative inotrope, so it reduces your cardiac contraction. And if the child has presented shut down, then your choice of antiarrhythmic is pretty limited. So of all of these antiarrhythmic, IV amiodarone is the safest. It has the least negative inotrope effect, but the negative inotrope effect is still there. Sometimes you may have to we may have to put the patient onto ECMO to take over the heart, and when you're doing a open chest ECMO, you can put in we can put in a temporary pacing wire to help with when I say overdrive, we basically pace higher than the tachy rate, and hopefully that can help to take control of the rhythm. And you can only do that after bringing the heart rate down to a certain level. You cannot overdrive pacing when the heart rate is beating at 200 or above beat per minute, because you won't have enough adequate cardiac output. Very rarely, in a extremely difficult case of atrial tachy, we may have to take the child to cath lab and do an emergency ablation, but this is extremely rare, and the child has to be a good size as well, so not a very easy decision to take. I think somebody raised their hand. Maybe we can do the discussion later. And then so case 4, let me see. Maybe I'll skip case 4 because I really want to show case 5, and I'm just being conscious of the time. So case 5, 15-year-old with palpitation when playing football. He felt dizzy. He feels like he's going to faint, but he didn't. So there's no loss of consciousness. They stopped him from playing. He looks pale, so paramedic was called and he was taken to the hospital. And in the hospital, this is the ECG you have. So if you can have a look at this ECG, and then I've got question to follow after this. I'm going to set my timer again, 20 seconds this time. Okay, right. So the patient was brought to your A&E. He's alert, he's talking, his blood pressure is stable. What do you want to do? You ring the Pediatric Cardiology Center, and the registrar is useless. He or she is saying that I will speak to my consultant, and they never get back to you. Obviously, you're worried about this ECG. Okay, I think there were 30-something response earlier, but we can move on. I'll give everybody another 10 minutes. Sorry, 10 seconds. So we've got 26 of us are going to give IV amiodarone, 2 going to give synchronized DC shock, 1 IV adenosine, and then 1 beta blocker. Okay, great. So what do you think of the ECG? This is exact the same ECG. So the child is still alert, talking to you. Okay, I think that's 31 response, fine. Yeah, so whoever answered pre-excited AF, you are the winner. So this is pre-excited AF. The reason this is not VF is because you would have lost your cardiac output. You wouldn't be alert and talking with a normal blood pressure if this is a ventricular fibrillation. I do see why people can think that this is a polymorphic VT, and I'm going to hopefully help you to differentiate between a pre-excited AF and a polymorphic VT. But the management is pretty much the same. So you, I'm not okay. Why did I put this? I can't remember. Anyway, I think I just put this just to show that, you know, you DC shock, and then you know, in a sinus rhythm, you see ventricular pre-excitation. So you've got your delta wave essentially. So the most obvious leads are literally everywhere, but for your eyes, so you've got very short PR interval, and then you've got the delta wave and a broad QRS complexes. Those are the 3 triads of ventricular pre-excitation, or what people call delta wave. Yeah. So in pre-excited AF, it's actually not uncommon in patient with accessory pathway. So a study shows that 10 to 30% of patients with accessory pathway, whether they have been symptomatic with palpitation or previously been totally, completely asymptomatic, um, can develop pre-excited AF. This is this is a medical emergency because the you've got the accessory pathway. Accessory pathway can conduct through the AV, from atrium to ventricle, what we call antegradely, and also retrogradely from ventricle to atrium, like what we saw with the SVT earlier. And when you have the presence of accessory pathway, in a pathway where you can conduct the electricity from the atrium to ventricle, imagine if your atrium goes into AF, the AF can go down the accessory pathway into the ventricle, and if you don't treat this, eventually it will turn into VF, and the patient can then collapse and die from a cardiac arrest. So the ECG characteristic are it's irregular. The rhythm is irregular. So there's no regularity of the RR interval. You've got the tachycardia, you got broad complex tachycardia with a changing QRS morphology. So if you look at the QRS complexes of every single beat, not all of them look exactly the same. And with polymorphic VT, it's often a little bit more chaotic than this. So sometimes you see the tossade as well, with polymorphic VT, but this doesn't have a tossade characteristic. It's more of it's the irregularity of the rhythm. So just remember, AF is always irregular. So if you look at somebody's look at an ECG of atrial fibrillation, you get irregular RR interval, and in pre-excited AF, so that irregularity remains. So just remember that. Yeah. So irregular rhythm brought QRS complexes, and not every single QRS complexes look exactly the same. Okay. And so I just want to say that in this paper, I'm just going to summarize it very quickly, that the patient who presented with pre-excited AF, they don't have to have previous palpitation, previous symptoms at all. So they can present with pre-excited AF as the first presentation, and then go on to be diagnosed with Wolff Parkinson White or accessory pathway. And so in terms of management, as I said, it's a medical emergency. It can deteriorate into VF, and the patient can die from it. What you want to do is to avoid giving any sort of AV node blocking agent. So avoid adenosine. You do not want to give those, because what is happening is that during, the patient is in AF, and the accessory pathway can conduct antegradely, and the AV node is also functioning, so you do not want to block the AV node and force all the conduction down the accessory pathway. So the best thing is to actually sedate the patient and shock the patient out of it. If I know some people have, given IV amiodarone, you got to give it very cautiously, because IV amiodarone can also block the AV node. So you got to be prepared with your pads and shock the patient out if you give amiodarone and the patient deteriorate into VF. So you got to be prepared. If you don't want to shock the patient, you prefer to go down the amiodarone route, be prepared that there's a high chance that you need to shock the patient out of it. So preferably DC shock. If you can't DC shock for whatever reason, then flecainide would be the next best choice. But obviously, in a peripheral hospital, we do understand that why sometimes you do not want to give that, because flecainide is not something that you often use in a secondary in a DGH setting. But how is flecainide different from the rest of the antiarrhythmic? Flecainide alters the property of the accessory pathway. It actually increases the refractory period of the accessory pathway, and this is how you're going to stop the conduction down the accessory pathway. And then once you've stabilized the patient and get the patient out of this pre-excited AF rhythm, then we keep the patient in, and then we plan for them to have ablation within the same admission, because the patient has already shown you that the pathway is dangerous, and if you let the patient go home, then that the patient is going to highly likely going to have another episode of pre-excited AF, and if it's unlucky, the patient will die. Yeah. Right. Okay. So I don't know if I still have time. If not, I can stop here and go straight to summary.
I think we have about 6 minutes.
Okay. This is
so
going to
whether
be
we
quick.
could do it really quickly.
Yeah.
Is that possible?
Yeah, this is going to be quick. Yeah. So 13-year-old girl, palpitation, dizziness, blur vision while sitting down doing homework, and then actually fainted. When her sister found her, she was unconscious and had urinary incontinence. They called the paramedic, and she came around just before they arrived, and she was taken to the hospital. And this is the ECG when the patient arrived. So as you can see over here, so these are the chest lead. The limb lead looks a bit more organized. The QRS are narrow, and this is obviously a different timing from the chest lead. So here you're seeing broad QRS complexes. If we go through the ECG systematically, we'll start with P wave. You can't really see where the P wave are in these clearly. So that could be a P wave if that's a T. So you've got some P wave here, which is in the wrong place. Maybe a P wave here as well. So it's definitely, the sinus node is not really firing consistently, and it's definitely not in a sinus rhythm. Looking at the QRS on the chest lead, it looks broad with 3 runs of broad complex, and then you've got your narrow QRS, and then followed by another 3 to 4 runs of broad QRS complexes. So there's some sort of ventricular ectopic or runs of non-sustained ventricular tachycardia going on. And if you look at the QRS pattern, they are all not very, they're not similar. So, when we are talking about monomorphic and polymorphic ventricular ectopics, monomorphic means that every single beat are exactly the same. Here, if you maybe V3 or V4, V2 or V3 are actually more prominent. Broad QRS complexes, they are not, morphology of it, they are not very consistent. So there's some sort of polymorphic ventricular ectopic going on. So in this in this scenario, you would start to think about something more along the line of, is this a cardiomyopathy, arrhythmogenic cardiomyopathy, or is this some sort of channelopathy? For the sharp eye, you'll see that the QT interval are actually quite long over here. So it raised a suspicion that this could be some sort of long QT. And while the child was in the hospital, we see this. Let me see whether, okay, no. So just want to point out to you, quite obvious in lead 2 and V5, maybe V5 are more obvious to some of you. You can see that, the T wave, so these are T wave, are different in every other beat. So this is what we call a T wave alternant. And you see this when there is some sort of myocardial repolarization instability. And it's a sign that, you know, this child is, it's a sign that the rhythm can degenerate into a torsade or polymorphic VT or VF. So do recognize this. If you see so always look at, you know, when you look at the ECG, make sure that you compare beat to beat and see whether there's any abnormal pattern going on. So this is T-wave alternance. You don't often see this, but if you see this, you want to pick your phone up and speak to your cardiac center immediately and transfer the patient out, whether you know what is actually going on. So the take-home message is that get a good history. You cannot do um, any less ECG, so more is better. Remember to do ECG during adenosine, before, during, and after adenosine was given, because it actually helped your cardiac center to help you. So again, remember that reentrant tachy are usually responsive to adenosine or DC shock because you can terminate the tachycardia. The rest of them are less responsive. So avoid IV adenosine when you see irregular broad complex tachy. If it is, you know, if the broad complex tachy is regular throughout, you can try adenosine if the patient is hemodynamically stable, awake, and all of that. But if you see that the rhythm is irregular, any sort of irregularity, avoid IV adenosine, because if this happened to be a pre-excited AF, you block the AV node, then you're going to send the patient straight into VF. So early stabilization in those presenting with hemodynamic instability. So think about speaking to the anesthetic team early to get help with intubation, sedation, central line, stuff like that. And then DC shock in an unstable child. And then the cardiac center are always happy to be contacted. I've worked in Brompton before, and we are very happy to give advice, whether it's small or big. So don't be shy. Just pick the phone up if you're not sure what you're doing. Thank you very much. And I believe you need to scan this code again.
Thank you so much, Dr. Yap. That was fantastic. Very, very useful session. I'm sure everybody agrees. And the cases were brilliant. The slides were fantastic as well. And actually using Mentimeter, I found it really useful because we could see your slides on Mentimeter. So thank you so much for a brilliant session. I know it's 2 o'clock, Dr. Yap. Is there any way that you would be able to stay for a few minutes for questions if anyone has them, please? Yeah. That's great. So if anybody has any questions, please do raise your hand or pop them in the chat function as well, which you should be able to see. Tracy, sorry, I think you've been waiting a while.
That's all right. Thank you so much for this. It's quite helpful. Back to the baby, we saw where we decided to either give shock or electric shock versus sedation. I had an issue with their ECG. I didn't want to think it was a sinus arrhythmia because there was a moment where it was a wider distance between the two RR complexes. And then there was a moment where it was, I think it was
which case was it?
Or 3. Either question 2 or 3, one of the two.
Case 2, you mean?
Yeah, either case 2 or case 3.
Let me see. We can go back. It doesn't allow me. Just stop sharing first, and then go on with your question.
Yes, so I just needed clarity on that ECG, if that's okay.
All right, I see. Okay.
Yeah.
Let me just try to. So what's your question again? Oh, clarity of the ECG. So let me see if this is what you meant. This one. Is it now? Got to share now. Is it this ECG or the one before?
It's this one.
Yeah, yeah. So this is
Yes.
atrial tachy. Yeah,
Okay, because I saw on lead 2, if you
yeah.
count 1, 2, 3, on the third one, it seemed wider.
Yeah,
So I got a little confused at that point.
that's the P wave. So if you look at I don't have a pointer. I'm not sure, how do I get a pointer up? Can I?
We can see your pointer.
Oh, can you? Okay.
Yeah.
Oh, brilliant. Yeah, yeah. Okay, so if you look at here in lead 1, I presume this is what you're talking about, the broad complex.
Yes.
Yeah. Yeah, so that's the P wave. So that's the atrial ectopic P wave. I mean, atrial tachy P wave.
Okay.
And yeah, because a broad complex will not look so small. It will be quite obvious if it is a broad complex QRS. So this is the P wave. Yeah.
All right. Thank you.
And again, this patient obviously is compromised. You would want to try to shock. Just bear in mind that in atrial tachy, if the shock often doesn't work, so just have to think about, maybe we should start the amiodarone ASAP.
All right. Thank you.
Yeah. Okay.
Don't know if we have any more questions. Selena's given some great feedback to you, Dr. Yap. It was such a brilliant teaching. Thank you so much.
Thank you, Selena.
Yeah, thank you, Selena, for recommending as well. It's great. So I don't think there's any more questions. I think everybody should have received a feedback form. Please do complete it so that we can provide Dr. Yap with some feedback today. And then after you've completed it, you'll get a certificate. If there's nothing else no more questions, we'll draw the teaching to a close. Thank you, Dr. Yap, and thank you everybody for joining today. Have a good afternoon, everyone.
Thank you very much. Bye-bye.
Thank you, Dr. Yap. Bye-bye.